So our next speaker is Dr. Scott Sullivan. He is the Vice Chair of Obstetrics and Maternal Fetal Medicine System Director at Inova Health in Falls Church, Virginia. He also holds a faculty appointment as Professor of Medical Education at the University of Virginia, and previously served as the Countess Alicia Spalding Paolozzi Endowed Chair, it's a full name there, of Obstetrics and Gynecology at the Medical University of South Carolina. Dr. Sullivan earned his medical degree and Bachelor of Arts in Biology from the University of Louisville and completed both his residency in OBGYN and Maternal Fetal Medicine Fellowship at MUSC. He also holds a Master of Science in Clinical Research. His leadership in academic medicine includes roles as Fellowship Director, Residency Program Director, and Vice Chair of Academic Affairs. And as we all know from earlier in this meeting, he also serves as the Chair of ACOG District 4. Let's welcome Dr. Sullivan and for his presentation, Prediction and Prevention of Preterm Birth, Is That Possible?
Thank you very much for that kind introduction, and good morning, everybody. Just a couple things. I'd like to thank the leaders of the Georgia OBGYN Society for the kind invitation to come speak. It's been an honor. I want to thank everybody for their hospitality and their graciousness to Jessica and I. We felt right at home all week, and I saw that everything that Dr. Suarez, Dr. Reed, Dr. Cheek have told me about this meeting over the years is absolutely true, and more. So you guys really have the secret sauce of how to throw a good meeting, how to plan a good meeting. And what a great crowd for Sunday morning. I am really impressed, especially after a slamming party, and I'm just thanks for showing up. I have given Sunday morning talks to a dozen people with like the moderators, so this is nice. This is really, really nice. So okay, so we're going to talk about preterm birth in one of my areas of research. It's going to dovetail with Dr. Baker's excellent talk yesterday. So you already he already answered this question for us, that you can prevent a few preterm births, some preterm births, but certainly not all. But I'll talk about a few more things. So no disclosures or conflicts. I will say that part of my talk is a little bit about some research that I've done and am doing. So I do have those trials funded, some by industry, some by the government. But either due to a lack of creativity or something, I don't make a penny out of any of it. If it becomes a big hit, I will not profit from it. So I always like to stress that. I might regret that someday, but it makes me feel better about talking about it anyway. So we'll talk about how we're doing with preterm birth, some of the difficulties we have with prediction, what are some options we have, what are we working on, and then of course prevention, which is something we would all love to do. So how are we doing? Not that great. I kind of like med-mal premiums, I guess. Not going the way we would like. About 10 years ago, excuse me, there was a little wobble in the preterm birth rates. They went down just a little bit, and everybody got excited. Thought, oh, perhaps it's the March of Dimes, perhaps it's 17p. No, it wasn't that. But those rates have come right back up to what they always have been. And if you look at, it's like all things with statistics, it's the window that you look at. If you go all the way back to the early 80s, the rate is about 10%. And it's been that way. And we haven't really made much of a dent in it, unfortunately, not from a lack of trying. And of course, we know that it's highly morbid. It accounts for 3 out of 4 of neonatal deaths, and the drivers, birth defects and sepsis. It's very expensive. It affects the budgets of Medicaid and insurers and families, of course. However you look at it, individually, as a system, a study that really needs to be updated estimated the cost in 2005 about $26 billion. And I've been playing with this a little bit now. It's probably around $250 billion now in the U.S. because of inflation, and now we can keep 23-weekers and 22-weekers going too. So all of the cost of prematurity has escalated. So it's an expensive, dangerous problem that we haven't made much progress on. Now, here's a picture of our shiny NICU. One of the things you'll see is in most hospital systems, one of the prettiest, largest places in the hospital is the ICU, the NICU. And it's great, if you have a 24-weeker, you really are happy that places have like this. But really, I consider these monuments to failure in some sense, that we have to build these massive, expensive places because we can't avoid the 10% of preterm birth. It's tertiary prevention. Primary, we're not very good at all. Secondary, steroids and transport and that type of thing, we're pretty good at that. And then tertiary, we're really good at that. But it's a shame, we would love to back all that up to primary prevention. Preterm birth is a regional issue. Some states it's not too bad, basically Vermont, and Oregon, and of course in the South we have higher rates of just about everything. I used to joke with my residents that I could just show this slide for everything: diabetes, obesity, preterm birth, a lack of insurance, you name it. And of course we all know that. But that's why you're here on a Sunday morning. I try to make this better, right? All of us. It's like go where the fire is, right? Now, sorry about this one. My mother told me to never insult your host, so I'm trying not to. Don't feel bad that like I say, I spent a lot of time in South Carolina, and we got the same grades all through the South. And all this is that the March of Dimes puts this out every year, as you know, just kind of showing the relative rates in states. And I used to have this exercise in South Carolina. Every year the rates would come out, and then the news media would call and say, come on the morning shows, and then they would yell at me for having an F. And like every year I would get yelled like it was all my fault. And they said, well, doctor, how would you feel if your kids came home with an F? Well, not very good, but I'd say we're working on this, and I would try to explain, all the problems of health inequities and disparities, but it has an impact, and this gets people's attention. But it's an issue all the way through the South, and it also highlights that the extreme disparities we have in all states, really, but particularly in the state, that if you're African American, or if you're in a rural area, or if you lack insurance, or you're underinsured, that your risk of preterm birth is higher, as much as 25% higher, which of course is another area of our research. And it's not just a U.S. problem, it's a worldwide problem. I gave this talk in Argentina, and I gave this talk in Jamaica, and similar rates. It's rising in Europe as well. For years they had a lower rate, and Europe is kind of catching up with us, unfortunately, due to a lot of the same problems. And it just accounts for a lot of morbidity worldwide. So why are we so bad about it? I want to talk about that a little bit. Well, one thing is that preterm birth is an outcome. It's not a diagnosis, right? About a third of preterm birth is medical: preeclampsia, diabetes, growth restriction. About a third is PPROM, which has different mechanisms, we know. Some is inflammation, some is infectious. About a third is spontaneous preterm birth. And when I was doing one of those shows once, they said, what causes preterm birth? I said, we don't really know. So we don't know what causes normal birth, right? We don't know the actual mechanisms for term birth, which kind of limits your ability to study preterm birth. So it's a need for like some basic research. And as you all heard on Friday, I love a good story. So this picture is my eldest daughter, born at 31 weeks, G1, no risk factors, long cervix, out of the blue, a Preterm while shopping for a dress, just boom, just right there. And then a 3-week NICU stay and chest tubes and ventilators and all of the like. So if it can happen to somebody who's being watched as closely as we were, who knows the risk factors, who knows what's going on, it's just illustrative that it can happen literally to anybody, if it can happen to us. And if you see my daughter, don't tell her I put that picture. She hates when I do that. She came to Atlanta once and learned I was doing this to her, and she really got mad at me. That's okay. I was like, it's really a good story. But yes, the worst month of my life, and of course, a lot of our families go through a lot worse. So one of the reasons we're not so good at it is because it happens to people like my wife and me. No risk factors at all. No history, no warning, boom. So if you don't know that's coming, how do you know, and of course, we don't really have much to intervene either, but if you knew who it was going to affect, you would focus more on them, but we don't. About 85% of our patients who have a preterm birth have no warning signs at all. So that's just right there in a nutshell why we're not very good at it, because it's everybody's at risk, essentially. So, I mean, clearly, we all focus on our patients who've had a history. We know that's a problem, right? They have a 30% risk of having another. And if they've had 2, they have a 50% risk. So obviously, we spend a lot of time with those patients, and we should. And as Dr. Baker's excellent talk highlighted, cervical lengths. It's the best screening program we have right now, and we do it, but it only picks up a minority of cases, 5%, 10% at best. So that is not a cure-all. It's something, but it doesn't help the other 85%. I won't belabor this one because we had a fantastic talk on it yesterday. It does help some people. And every time I'm on call, I'm putting in a cerclage, it seems, and it does help some people. And yes, I even do those 4 centimeter, 5 centimeter ones, acrobatic, put it in and pray type of thing. But some people actually do quite well with it, and it is worth in that 10%. It is worth doing, and as Dr. Baker pointed out. What are other things you can look at? You can look at demographics. There's a good paper that showed your zip code affected your risk, which was perhaps environmental exposure, certainly insurance, and certainly racism and other types of things elevate your risk. There are biomarkers, which I'm going to talk a little bit about, which may be the next wave of a prediction for those asymptomatic people. There's a lot of them: fetal fibronectin, IL-6, tumor necrosis factor, a number of things. Symptoms, residents, when we go through this, are often shocked that symptoms, contractions, pain, even dilation, is a poor predictor of a preterm birth. It's most people who have symptoms do just fine. And as you know, we end up over-treating a lot of people because of symptoms. So symptoms ultimately isn't a good predictor either. So one of the things, I was always interested in preterm birth. After a month in the NICU, I became very, very interested in preterm birth and started doing more research on it. So we really sat down with a group of MFMs across the U.S., and we said, what would be a good predictor? If we could dream one up, if we could order one, what would it be? This is kind of what we came up with. Well, it'd be something, minimally invasive, not like a biopsy or anything. Something you could do early, something you could do that everybody could do. It wouldn't just be in MFM offices. Something accurate, obviously. Cost-effective, that's often the hard one, right? Especially when you're coming up with new things. And then something you could actually do something about, something actionable, right? So that would be great. We as I walk you through some of the trials, I'll say we're inching our way this way, but I'd say that we're not really quite there yet. So, as I mentioned, I doubt that there will ever be a single treatment for a preterm birth, because the same thing that reduces preeclampsia is not likely to reduce PPROM, or if you treat inflammation, that may not actually help you with infection. So, and there's multiple routes of activation. So probably it's going to be a basket of interventions or a series of interventions that may ultimately help us. So our first study in this large study group was to try to come up with a biomarker for a preterm birth. And our first paper is almost 10 years ago. And we sat down and we started with 500 possible biomarkers and did run after run after run after run, and then ultimately kind of settled on that there are our particular test, 2 biomarkers. And this was a large study, over 5,000 patients across 11 centers with a broad range of geographic representation in our samples. And we just said, will this thing work? Can we come up with a predictor? And that's just the flow of the patients. We excluded some people who were on progesterone and who had medical preterm birth. So this is what we ended up with, ultimately. To our surprise, this wasn't sort of on our initial suspect list, but we found that sex hormone binding globulin and insulin-like growth factor 4 move in opposite directions if you have a term birth or a preterm birth, which makes them very good predictors. And you can follow them, which is most likely due to inflammation for most people. And so for preterm, the sex hormone binding globulin goes down, and the insulin-like growth factor goes up. And so that's helpful when you're looking at biomarkers. So long story short, this test, which is a blood test done about 18 to 20 weeks, so it fits those criteria, easy, available, done in the office, actually works pretty darn well. And this test will detect almost all preterm births under 35 weeks, and about 75% of preterm birth under 37 weeks, which is a whole lot better than symptoms, right? And short cervix. Short cervix is about 5 or 10%, and symptoms about the same. So this was pretty cool. We were really excited about this because it was a new tool, something we didn't know about before, and we all felt pretty proud about this, that it was a cool thing. But remember that list I came up with? What was the flaw in this excitement? Well, what do I do about it now? Right? And this is probably why you haven't ever heard of this or haven't used it, because, all right, I have a test. You're going to have a preterm birth. Sorry about that. Stick close. Call me if you have any symptoms. And I guess small things, right? Maybe we should give you steroids. Maybe you shouldn't go on that trip to Belize. Maybe things like that. But what do I actually do about it? And so here's just what that test. It shows a percentage and your risk from baseline. And since 2016, you can order this test. You can just order it and draw it. You could do it right now. I know you're not, and I'm going to tell you, you probably shouldn't right now. But it's been available since 2016. Now, I want to point out that there are many other biomarkers out there. There aren't many commercially available. Quantitative fetal fibronectin actually has a very similar prediction profile, but nobody has taken it actually to making it available. It's only really available in a study setting, so you couldn't order that if you wanted it. But I think this, and there are other biomarkers in the pipeline as well. But again, so here's a picture. We had a press conference right after we presented this at SMFM, and if you look at the expression on my face, I'm like, what do we do now? I have no idea. It's like, great, it's exciting, new tool, what's next? It was a real problem. So some people are like, well, let's just start doing it and try stuff. We're like, well, that's not how you do responsible medicine. You have to figure out how this works, and you don't just spend money because it's there. So, but we have been doing trials since then, and we've just released a few, which I'll talk about in a minute. So, but it was a little bit frustrating to have a shiny, new, cool toy that you couldn't really do much with. But it really was good with research, because if you think about it, 1 in 10 preterm birth, you have to recruit 10 people to get 1 preterm birth. But if you can send this test and get a 50% chance of preterm birth, you can recruit 2 people and try stuff. And that's actually what we've been doing in the last 9 years, which I'll point out. So it makes doing trials a lot faster, which is nice. So what else can we do in the interim? I just Googled pregnancy and smoking, and that's what came up. Very strange. But I trained in Kentucky, where 25% of the preterm births are related to smoking. We used to call it the abruption of the day. A young, otherwise healthy woman would come in just hosing blood and abrupting because she's a heavy smoker, and because that's a big risk. Now, that's not a higher risk everywhere, but it depends on where you are. But so if you can get your patients to quit smoking, you have reduced preterm birth. That actually works, and it's very powerful. And as I point out to residents and fellows, we all love new tools and expensive toys and things like that, but a lot of what we do is just retail, day in and day out, individual patients, and making a difference. And it's really, really important, because our preterm birth rate would be a lot higher without what you do every single day. So screening people for cervicitis and treating that reduces preterm birth. If you have chlamydia cervicitis, your risk of preterm birth is 22% if it's untreated. So if you catch that and treat it, you've reduced preterm birth. If you screen for asymptomatic bacteriuria and keep people from getting a UTI or pyelo, reduces preterm birth. And it's the same if you screen for domestic violence, alcohol use, that works too. Aspirin, I could give a whole talk, and if you invite me back next year to the cloisters, Ben, just saying, I'm available. No, I'd love to give a whole talk about aspirin, because how I mentioned a third of preterm birth is medical, right? Because this marker that I've been working on does not really, there's some interesting stuff with that, but it's not really focused on that. But if everybody who was a candidate for aspirin actually took it, the way it would have a huge impact on medical or preterm birth, or at a minimum delay it, right? Because I mentioned those NICU costs. If you're 35 weeks versus 32 weeks, huge difference. Not only cost, but like long-term outcome. So aspirin really, really is a continuing success story. Now, tons of questions. 81 versus 162. How often do you have to take it for it to be effective? When you stop it, tons of questions. But we do know that for preeclampsia and FGR now, we know it actually does reduce that. So again, we do have some tools. Weight management, and we talked about Hester Closh. So it's not like the toolbox is completely bare. It's not. I mentioned aspirin. I got ahead of myself a little bit. It can reduce now somewhere between 10 and 25% of medical preterm birth, and that's exciting. And it's funny. The first wave is usually the basic science, and then the translational folks, and then you have the kind of epidemiologists who point out, well, only about a third of people actually take it after you recommend it, and only about 2/3 of people are actually even told that they should take it. So you identify a tool and an application, but you say we don't apply it properly, or we don't get it to where it needs to be. So that's another part of this, is we have to get aspirin in the hands of people who need it, and fortunately it's cheap and safe. Now there's some things that don't work. Again, I keep talking about Dr. Baker. I should give you a cut here. The bed rest, that doesn't work, and it's dangerous, in fact. Pessary, as we talked about, it was really exciting for a while, but everything since then has been negative. work restrictions, maintenance tocolysis. My residents love maintenance tocolysis. Like, here's some Picardia, just take this. It'll work. It doesn't work. It cuts down ER visits and phone calls. Actually, that is a good paper, but it does not prolong. It doesn't prolong gestation. And treating BV, again, one of those disappointing moments, right? BV is associated with preterm birth strongly. Okay, let's screen and treat people for that. That makes sense, right? Negative. Not only negative, just like we found with bed rest, if you screened and treated people, oddly, their risk of preterm birth went up. Can't explain that one. Like, was it the treatment? Was it some kind of toxic reaction? What was it, a statistical blip? I don't know, but we stopped doing it after that, for sure, which is, again, very confusing, though. What are we missing? Some research that we're still working on, a folate supplementation may reduce preterm birth. Nutrition, Dr. Ray's great talk, food is medicine, and health begins in the kitchen. What a great phrase. I stole that one. I wrote that one down. So true. And if you eat seafood twice a week, your rate of preterm birth seems to go down, which even in Charleston, we did a survey. We're sitting on the ocean. Only 20% of people get one serving a week of seafood because they're all afraid of mercury, and it's expensive, and it's just not commonly known. But it reduces preterm birth. Some evidence that vitamin D may as well. We did a nurses study and found that 97% of our nurses were vitamin D deficient, and most people had none. I mean, no detectable range of vitamin D. So it's very common because it's not in foods really, and we don't work outside much, and you don't get much from the fluorescent lights. So that's another issue. Mental health treatment. In Virginia, it's the number one killer of pregnant women. So screening and treating. Stress, racism, depression, anxiety, all strongly contributes to a preterm birth. And of course now, again, Dr. Ray said he would hire psychiatrists. I completely agree. I would be right there with you. If I win the Powerball, that's what I'm going to do too. We have 21,000 births in our system, and we have 3 psychiatrists. I sat down with them. I said, how many do we need? And they said, 90. We had 3. I was like, well, I'm going to put in a request for 2 more. We'll work our way up to 90. But what that actually means is a lot of it falls on us, right? In terms of the initial screening and the initial counseling and even treatment, which not all of us are comfortable with, right? I know, because it's not really a huge part of training in some places, and it's just uncomfortable. It's outside of our day-to-day, but it basically has to be. And on and on. And great study in Massachusetts that when they covered IVF and people stopped putting in 2, 3 embryos because they didn't have to, because they could put in one, they could accept the lower rates, and they could put in another one. The rate of twins and triplets went down, and the rate of prematurity went down. So again, small things that don't directly affect it, but can reduce preterm birth. One of the coolest things, I think, is that just being you, reduces preterm birth. It's called the Dyson effect. Nice little trial done in France by Dr. Dyson, who showed that just reaching out to a patient, how you doing? How you feeling? Have your prescriptions? Have your appointment set? Do you need anything? Just a check-in weekly significantly reduced preterm birth. It's pretty cheap, right? I mean, relative to other things. And it's been replicated multiple times. As Dr. Rittenberg, my colleague from MUSC, showed that if you gave people 17, of course it turned out 17p didn't work, but phone calls plus 17p was better than 17p alone. Dr. Newman and myself set up a preterm birth office and clinic, which the mainstay was weekly contact, just calling people, checking in, and I mentioned racism before, and anxiety, sometimes it's just the support. Somebody cares about me, somebody's looking out for me, somebody's interested in me, has a positive psychological effect, which turns into a physical effect. And we now know it doesn't matter if it's an RN, an MD, a person with a script that's written by you, or telemedicine, or phone, or in person. It seems to work consistently, which is really pretty cool. So that we know we have a positive effect on people. Now, can you see all your patients every week during pregnancy? No. But again, that's why it's important that we can figure out who we should be talking to more regularly. All right, I mentioned 17P. Sigh. Okay, this was a tough one, right? The weird quirks of, I teach students and residents about statistics and studies, and this is case number 1 of what can happen with type 1 error, right? You can do a well-funded, multi-center trial with great people, with all the safeguards, and every time you do that, there's a 5% chance you'll find something that's not there. That's 20 studies, right? So that can happen. So that's why we repeat things. Now, the weird thing about 17P, this came out, I remember I was at SMFM, everyone just was like, wow, we finally have something. Let's jump on it. We jumped on it. They didn't repeat this study for 16 years, which is really, really weird. When I did our antibiotic trial, preoperative versus cord clamping, that was kind of my thing, it was there were 6 replications in a year. It was replicated everywhere, just really quick. People were like, let's see if that's true. It was weird for 17P. Nothing happened. Everyone just said, okay, that's good. The problem is when we repeated it, which the FDA required after 16 years, they were like, hey guys, you're supposed to do this. They repeated it, stone cold negative. Stone cold negative. Now again, lots of arguments. It was done in, say, Eastern Europe and slightly different ways. And might it work in some situations and not in others? But the fact of it is, it was a large negative study, and the FDA pulled it. You can't even really get it now unless you compound it in your basement, which isn't good. So I still get patients who ask me for it because they had it before or somebody they know, and it's uncomfortable. But now, what we often do is we offer them the vaginal version, which still feels kind of uncomfortable because we're not completely sure it works for this indication either. It might. There are some trials that are positive and some trials that are negative. One of the largest RCTs was negative. There was a trend, but trends aren't actually proof. So this is one of those uncomfortable things. Again, as Dr. Brooks pointed out, ACOG, when there's a lack of evidence, they don't like to come down on one side or the other. They just say, maybe you can consider it. And that's true because we don't really know if it works or not. So if a patient has a preterm birth or a short cervix, it's something you can consider and offer, but I always say it with a lot of caveats, right? It might help, not totally sure, probably doesn't hurt, there's an expense, and on, and so it's not a cut and dried conversation. A meta-review in 2017 for the indication of prior preterm birth showed that it may work. Now again, a meta-review is just a combination of other studies, so it's not absolutely proven, but it may help some people, so I do sometimes use it. I mentioned cerclage, I won't go through that. Pessary, Dr. Baker covered that really well, so I won't go through that. And of course, we have other things. Again, as Dr. Brooks said, basic research. We desperately need understanding of normal birth, understanding of the mechanisms of preterm birth, and we need other tools. We need a lot of other tools if we're going to actually solve this. So, universal screening. Well, of course, after our trial came out, people were like, should we use this on people? And I publicly and often said no, because if we don't know how to treat people, don't screen anybody. We teach our interns that, right? With cervical length, we have something, right? If you find it, you can offer them a cerclage and maybe progesterone, so that makes sense. But for ours, at least initially, that didn't make sense. Okay, so the follow-up trial, which is kind of cool. We presented this at SMFM in February, and it's coming out in the Gray Journal in a few weeks. So we did a follow-up. It took a while. 6,500 subjects, again, RCT, multi-centered, very expensive, took a long time. So we took people who screened positive, and, well, it was randomized, actually. So half the people, they got their blood drawn and put away. So they just got treated like everybody else. And then the other half, you were screened, everybody knew it, positive or negative, and then we treated the positive people. And you see, okay, does that make a difference? Does it reduce preterm birth? If you say, well, what did you do for him? This took almost 2 years to decide. Because, like, when we first started this, 17P was still a thing. I'm glad we didn't go that way. So we offered everybody a cervical length. We offered them a prometrium if it was positive, a vaginal progesterone, weekly contact, the Dyson effect, and aspirin, the medical effect. So we threw everything at them, essentially, which is a flaw in the study. You have to just be honest about it, but that's the way we did this one. When you do an RCT, you have to pick certain parameters, and there's pros and cons. So, of course, here's our results. At 2,500 in the prevention arm, 2,500 in the control arm, and you see that the total is only 5,000. And the reason was the Safety and Monitoring Board, which was independent, stopped the trial at 5,000 for efficacy. And they said, you need to stop doing this and just present your results, which was kind of cool. Actually, I've done a lot of trials in my life. That's the first time that's ever happened to me. I've had them stopped for futility, which is a bummer, but still, you need to know. But this was the first time that that's ever happened. That actually made the news. Somehow that got out. It was just like, this trial's been stopped for efficacy. It wasn't any of us. But so that was kind of cool. So we then said, okay, well, how well does this work? So lots of results on this. I won't go through all of it. But essentially, it worked pretty well. That basket of interventions, if you screened positive, you had a lower rate of preterm birth, you had a lower rate of a NICU admission, you had a lower NICU length of stay, because it actually shifted things to the right. Even if you didn't avoid the preterm birth, it seemed to push it more towards term, as opposed to if you weren't treated. So that was pretty cool. Again, another one of those cool moments with very significant p-values and a 20% reduction in that length of stay and a 25% reduction in neonatal morbidity. And if you remember from Dr. Baker's talk, with a cervical length, you need to screen about 150 people to have an effect. And with this particular approach, you need to screen about 40 people to avoid one NICU admission. So that works pretty well. Now again, caution, it's the first trial, right? It's like, here we are with 17P again. Again, everyone's like, should we be doing this? I'm like, not yet. Let's do this again. Let's do this in a different setting. Let's look at the different interventions and stratify that, which we're doing. Also in this data, to avoid one NICU admission, if you had Medicaid insurance, the number to screen was 3. So if that pans out, that's pretty significant, right? And that may reduce a lot of things. Again, I'm just saying we're being cautious about this, but it's pretty exciting. So look for that in the Gray Journal and the follow-ups, and we have a lot more trials coming down the line. But again, it's taken 20 years to get to this point, but we're going to keep going. So in summary, preterm birth, a huge, dangerous, expensive problem, something we deal with every day. Our current tools, we do have some. I don't want to make it all negative, and what you do every day for your patients makes a huge difference. It would be 15, 18% if it wasn't for what you do. But we don't have enough current tools. We don't have enough basic understanding. We need more research from the NIH, from industry, from everywhere. We need new tools. And now with this test, we're thinking, well, let's look at some other things. Let's look at statins. Let's look at GLP-1s. Let's look at N-acetylcysteine. Let's look at some other tools that we can now do much more quickly if we have a higher risk population to actually look at. So that will be our next wave of research, and not just us, all across the OBG community. So, and the little things, again, I want to stress the positive on that we do help our patients every single day in what we do. So that's how Abby turned out okay. That was a few months ago, so she did fine. But we all know, we've all had patients and who haven't been as lucky, and that's why we are here on Sunday at 8 a.m., not at home, not at the beach, but trying to make things better. And I thank you for doing that, and I thank you for listening. If anybody has any questions, I'm happy to take them.
Hi, thank you for that. That was really quite informative.
Thank you.
So was the Dyson effect piece standardized? So if you were to do this in a lower resource population, and perhaps if you're going to stratify, the medical plus the social interaction, do you know if the people reaching out went through a structured interview and addressing social determinants or different pieces like that?
Absolutely, they did, in fact, and it's a great point that there are other examples like centering in pregnancy and other types of approaches where there is more of a support component and a anti-racism and coaching component that the Dyson effect is enhanced, actually, if you address those things. So in this trial, they were, at the early part of pregnancy, they were screening for SDOH and asking questions about other things than medical, like do you have like food insecurity and housing insecurity, and then as things went on, it was more of a check-in and a follow-up. But they were trained, and they did have training up front on screening for those important things. Because you're exactly right, Dyson effect has levels, and the more evidence-based things you put in there in the contact, the better it works. Thank you so much.
Thank you, Dr. Sullivan. Appreciate it.
You bet.
I think I have a little bit more of a hypothetical question.
Sure.
Of course, coming from MFM.
No, right.
I mean, right? So speaking from that
Absolutely.
side.
Yes, very used to it. Yes.
So we've been doing this forever, 20 years, right? We've been doing this. We keep kind of saying the same things over and over again. And I think we've hit a point where we all know within the field, preterm birth is of multiple phenotypes and even spontaneous preterm birth. So let's forget the split between iatrogenic versus spontaneous. But even within spontaneous, I think we all realize there's probably different phenotypes, which is why we see the people who survive with the 4-centimeter cerclage versus the others, and et cetera.
Yes.
And I'm just curious that with all of the data sets that we have, especially from MFMU as well, with some of our progesterone studies and other pieces, would this be the one time where we think about a machine learning AI model to put in all of the data, to actually then look at, can we first divide the phenotypes of preterm birth, and then maybe get a more effective targeted intervention that actually has impact? And I say this very philosophically because I feel like I do this at every SMFM. I'm sitting there thinking in the audience the same thing. And I'm not a preterm birth researcher. My area is metabolic health, of course, preeclampsia. But, it's the same thing, right? Like we all as MFMs are going through this. So I'm just going to put that out there because it's something I've always just pondered. I ask Bill, I ask, all the peoples. But is it time we think about this, especially with the modeling that we're able to do now from that perspective? And not the kind of modeling that got presented at SMFM where they just put in ACEs and CTQs and things, but like actually getting in the raw data.
Thank you for your question. And that absolutely, it goes back to my blanket statement that we won't make a huge impact and leap until we have a basic understanding of what we're actually attacking and doing, because it's all very general, right? You saw our interventions was just throw everything we possibly know and see what sticks, and it was very bothersome, right? That is not the way you typically would do a trial, but it's because of what you say. Dr. Romero has done a lot on the phenotypes, and actually I'm working on a paper with him now that in amnio samples that we seem to have identified 5 different phenotypes. Sterile inflammation, infection, nothing, which is mysterious, right? Infection and inflammation, and so on. And so, antimicrobials may work for that one, but it's not going to do anything for the inflammation or the mysterious group, right? So you're 100% right, that we have to. Now, I'm not an AI guy, so I don't exactly know. I'm hopeful, right? Every time we get new technologies and new techniques, that it's an opportunity. So, but your overall point is completely accurate, that we have to bridge that gap before we really, because we're just guessing, right? With statins too, like, well, it has an anti-inflammatory effect and it has other effects. Let's try that, right? That's really not how you would ideally do science, right? You would find the problem and then find the solution to the problem rather than saying, well, I hope this works, right? But it's where we are. Dr. Baker. You deserve this because I kept quoting you.
Oh, and I appreciate that. I don't get a lot of love these days, so thank you, sir. Great talk, Scott. Thank you so much for that presentation. In the study that you presented, or for any of the studies that you've done with this blood test, have any of them looked at it, how it performs in multiple gestations?
No.
Okay.
Is the short answer. I think that is our next area, among other things. Currently we're looking at like subgroups, like for say certain demographic groups, certain insurance groups, and then looking at the actual preterm birth groups, like the medical group and the PPROM group and things like that. So we're kind of cutting up that data. But yes, there's like 6 new trials ongoing because of the enthusiasm for this one, and multiples is the next one as well.
Great, thank you.
Thanks so much. All right, thanks y'all. Again, thanks for having me.